What's up, everybody? Dr. Rossi, StreetsandSneakers.com. So I've been talking about ADHD. In the first video, we discussed the diagnosis, what are the common symptoms, how do you differentiate between inattentive, primarily hyperactive, primarily impulsive, and what are some of the different criteria to make that diagnosis. In this video, I want to focus on the ADHD treatment protocols, and I'm not going to go into great depth on each medication, but I'm going to talk about the common ways that this is treated, and then we can kind of break down medications based on which ones you guys have questions about. So, what can we say about the treatment? This is one of the few disorders where medication is the first line treatment, and medication above any type of behavioral intervention, any type of other talk therapy, medication seems to come out as the best choice for treatment of ADHD. And this is a board question. This is something that's well known and well established within the literature. So medication works really well for the treatment of ADHD and is the first line option for a child or adolescent or adult diagnosed with ADHD. So there's a 70 to 80% response to psychostimulants. And when I'm talking about psychostimulants, I'm talking about things like amphetamine sulfate or methylphenidate. Those two medications are very, very common choices when you're talking about psychostimulants. So 70 to 80% response rate is very significant and very good. For preschool age children, it may not be the first line intervention medication. And that's just because the kids are very young at that point. They're not in school. They don't have that need for focus and attention the way a school age child does. What usually happens there is you start with behavioral interventions with those kids, and then if they're not doing well and they're having significant functional impairment, medication can be considered. Although this is not a very common situation in clinical practice, we're mostly dealing with school-age children who have difficulty with ADHD. So let's crack into those psychostimulants that I'm talking about, and I'm going to start with methylphenidate, and you might know methylphenidate better by its brand name, which is Ritalin. So Ritalin Methylphenidate, basically with that medication you're going to start it at 2.5 milligrams to 5 milligrams twice daily. You want to take it before breakfast and before lunch, and again we want to keep this medication earlier in the day so it doesn't interrupt sleep patterns. Now that medication can be increased by 2.5 to 5 milligrams per day, reaching an optimal dose that's actually weight-based. So the optimal dose will be 1 milligram per kilogram per day. So that would be how you would dose it. If you were trying to optimize it, the maximum is 2 milligram per kilogram per day. The side effects are things you might expect with a stimulant, things like insomnia. So again, we take it earlier in the day because we don't want to risk sleep interruption. Decreased appetite. Stimulants often decrease appetite. People use those to sometimes as part of weight loss treatments. Mood disturbances. Obviously, if you're increasing some of these neurotransmitters, you're going to potentially create mood disturbances. Tics, which are common in things like Tourette's disorder, but tics can occur with these stimulants. Headaches, GI distress, and rarely psychosis, right? Because in these cases we're increasing dopamine, and we think that an increase in dopamine or an excess in dopamine has a lot to do with the symptoms of psychosis. So those are some of the common side effects. Now with methylphenidate, there are several long-acting preparations, and I always talk to you guys about this because I believe that if we can use extended release medications, it's a better option. So extended release is the best option, and that helps us in a couple ways. It also limits the potential addictive nature of these medications when you use extended release, because you're not getting those peak plasma levels right away when you take the medication, which often lead to things like euphoria, and hence will create the conditions for possible addiction. So long-acting preparations include things like Ritalin XR, Ritalin LA, Metadate, Concerta, Focalin XR, and several others. Basically, there's a whole bunch of these medications that have sort of different release mechanisms, and they're all marketed under different names. It's a little complicated, but again, knowing the basics here is what we're trying to go for. So the important thing about the long-acting preparations is that they provide a sustained second release that results in a plasma level that lasts somewhere between 4 and 12 hours. So if you think about it, depending on the preparation, if you're using these long-acting medications, in most cases they should cover a child for an entire day, right? It should, like an entire school day. I mean, it's not 24 hours, but we don't want that, right? Because we don't want to interrupt their sleep and things of that nature. But we do want to provide a sustained release over the course of the time that they're in school. Now, a second popular option for psychostimulants is something called amphetamine sulfate, and you guys might know that better as Adderall. So Adderall can be started at 2.5 to 5 milligrams per day, once or twice per day, depending on how you want to dose it. It can be increased by 5 milligrams per week, and the optimal dose is somewhere between 0.5 and 1 milligram per kilogram per day. Now, dextroamphetamine, so that's another formulation of this, is twice as potent as amphetamine, so you got to be mindful of the dosing. If you're switching someone from amphetamine to dextroamphetamine, you're going to want to make sure you reduce that dose a little bit because it's going to be more potent. Now, the side effect profile for amphetamine is actually quite similar to what we see with methylphenidate, so you got to look out for things like insomnia, decreased appetite, mood disturbance, tics, headaches, GI distress, and in rare cases, psychosis. There are also long-acting amphetamine preparations, and those include things like Adderall XR, Dexedrine, Vyvanse, which is formulated as a prodrug to reduce the risk of abuse, and these will all provide coverage for about 12 hours. Again, we're going to want to make sure we're covering that person over the course of a work day or over the course of a school day. There is an important black box warning that I want to mention here, and that is that there's a risk for abuse and dependence. In addition to the risk for abuse and dependence, there's also cardiovascular safety warning regarding the risk of sudden cardiac death. So in children or adolescents with structural heart defects or those with severe cardiac conditions, you're not going to want to use this medication. And you're going to want to screen for this by asking the patient's family about any cardiovascular disorders and if there's any family history of what's called sudden cardiac death. Now, I know in clinical practice that I've always done, we always do an EKG. Even if it's not really indicated, say there's no history of cardiac disease, there's no family history of sudden cardiac death, we do the EKG anyway because it's a safety issue, and we want to have one on file just to be able to say, hey, we did look into this, we did make sure that there's no issues, and prescribing this medication is appropriate based on the normal EKG. So I'm going to stop there with this video. If you guys have specific questions about the medications, or you want to see methylphenidate or amphetamine sulfate covered, individually as on a deeper level, discussing the mechanism of action, things of that nature, be happy to do that in another video. And please like and subscribe to the channel so we can continue making videos.